If left unchecked, they can kill the organism. Okay? Cancer cells can go on dividing indefinitely if they are given a continuous supply of nutrients. Okay, even though they have been dominating the area or the organs. Okay, normal mammalian cells growing in culture only divide 20 to 50 times before they stop dividing. So, if you culture these normal cells, okay, in the lab, in the flask or in a petri dish, okay, once the cells are convinced, they will say that okay, we should stop dividing, stop growing, okay. But the cancer cells don't. So they can even grow overlapping on top of each other. Okay, that's how they behave, right? Okay, and they don't have a contact inhibition. Contact inhibition means that, let's say in the lab, okay, in the culture setting, when they sense that okay, there's cells very close to them, there's no more space, okay, they will stop dividing. Okay, and same thing in your physiological, in your body. Okay, so when the normal cells will tell you to stop duplicating, okay, stop growing when there is other cells nearby on the organs, for example. Okay, but cancer cells don't, and they can grow on top of each other when the total area in the flask or in the petri dish, depends on your lab setting, has been covered. And they may produce required external growth factors or override factors themselves, or possess abnormal signal transduction sequences which falls it convey growth signals, thereby bypass normal growth checks. Okay, so normal growth check memang adalah in the normal cells, but these cancer cells bypass. Why we need to know this? It is very close related with the strategy when you want to kill the cancer cells, as in the anti-cancer mechanism of action per se, because of the you have a various type of cancer cells, different stages. They will give you a different response towards anti-cancer agents. So you cannot have just one anti-cancer agent with the mechanism of action. You need to target as much as you can, okay, when we talk about cancer. Cancer cells exhibit irregular growth sequences. If growth of cancer cells does so at random points of the cell cycle. So basically, they are abnormal. If they stop growing, they can stop at any stage. Okay, so this is what you see under the microscope. Okay, for the cancer cells in the flask, if you grow the cancer cells, right? So if you look at A, they are quite ugly as compared to the normal cells, correct? Okay, in normal cells, you can see the membrane is very intact. You can see the organelle is nice and beautiful, and if they have a nucleus, you can see everything is nice. But for the cancer cells, you see, you can't even differentiate which one, like individually. You can't tell where is the boundary of the membrane, the organelles, the nucleus, okay? And then B, if you zoom, you see that the membrane is irregular, okay? Like almost similar with the necrotic features. Alright, kalau necrosis, you see the membrane is irregular, okay? But they are healthy cancer cells, okay? So this is about, I would say this is about 95% confluence, which normal cells, it's difficult to grow normal cells in a petri dish or in a flask. It's very, very difficult. At the moment, I'm growing human endothelial cells for my research, because I'm I'm studying the thrombosis, the coagulation in the coronavirus, so we need a normal HUVEC cells. And it's very difficult to grow, very expensive, and the passage number means that how many times they can duplicate before we have to terminate the cells, we cannot use the cells. Okay, it's only 7 times. But these cells can grow like 50 times, and they can even grow on top of each other. There's no contact inhibition. So you see, if you understand the nature of the cancer cells, it's very difficult to kill them. So when you want to target pharmacologically, right? You keep thinking, okay, which signaling pathway that is more efficient, or you might need 10, for example, or you need more than 2 or 3. So that is the basis of the combined regimen. Okay, so usually for cancer, pharmacological treatment or intervention, kita tak guna single agent. Okay, right? Okay, so this is the cell cycle. I hope you still remember. Okay, this just to show you the hypothesis. I think you belajar dalam biochem or pathology how it looks like. Okay, and this is under fluorescent microscope. You can see the condensation. This is all the apoptotic cancer cells. Okay, and why do we target apoptosis rather than necrosis? Because apoptosis is a programmed cell death. So basically the cells kill themselves, correct? Okay, so necrotic is more trauma. It's more traumatic to maybe to the other normal cells. Okay, so theoretically we want the cells, the cancer cells, to die, and they die by themselves through the apoptosis. Okay, so do we have an drugs, the agent, to ask these cancer cells to start apoptosis process? Okay. Okay, this is your learning outcomes for this topic. Okay, just generally, okay, the intervention or what we do in the case of cancer patient. Okay, people will say that okay, first is chemotherapy, but actually chemotherapy is the second. Okay, the first one is radiation or surgery. If you can remove the affected organs or the cancer cells or the lung, for example, you do that first. Okay, for example, the lung has been detected in the one of the breast. Okay, and the doctors will remove by surgery, and then based on the biopsy results, we see whether what type of cancer is it. Okay, and then if chemotherapy is needed, then we start chemotherapy. Okay, sometimes the chemotherapy is even first before any surgery because we want to shrink the size of the tumor. Okay, right. But chemotherapy is not the first time. Okay, it depends on the type of the cancer cells as well. Okay. 1/3 of patients without metastasis respond to surgery and radiation. If diagnosed at an early stage, close to 50% cancer could be cured. Okay. For chemotherapy, 50% patient will undergo chemotherapy to remove macrometastasis. However, chemotherapy is able to cure only about 10 to 15% of all cancer patients. Okay. Right, so this is the apoptosis pathway. Okay, I think you have somehow pernah nampak lah this pathway, okay, signaling. Okay, and in cancer cells, in some cases, okay, if you have a mutation in one of these proteins that are involved in the apoptosis pathway, that will increase the proliferation and survival of the cancer cells. Okay, so logically, if you have any agents that targets a certain step in the apoptosis pathway, which may be mutated, so you might have a potential anti-cancer agent. Okay. Okay. So when we talk about anti-cancer, okay, so it's not really straightforward because when you have drug and your target, okay, your receptors, couple your cells, okay, right, then you have a drug target or drug receptors complex, and then it should cause a damage to the cancer cells. Okay, so certain agent cause a catastrophic death, okay, necrotizing the cancer cells. Okay, but what we want is the apoptosis, okay, where it's it's the ultimate or the target hypothesis because we will try to minimize the toxicity on the normal cells. So hypothesis is the best choice. But there are issues with the anti-cancer, okay? Just like antibiotic where you have a resistance from the bacterial factors. Okay. Now anti-cancer agent pun sama. We have problem with drug resistance. That is why the response tak sama inter-individual. Although they have the same type of cancer, the stage are the same, but they might not have the same outcome. Okay. So what are the mechanism of chemotherapy resistance? Okay, the first thing is decreased influx. Okay, so means that you have the agent, the anti-cancer, but the drugs cannot get into the cells. This is particularly with the agents or drugs that needs a transporter to get into the cells. Okay. And the second one is increased efflux, where you have a transporter. The cells express more transporter, so they pump out the anti-cancer agent from the cells. Okay, right. And the rest of the mechanism of chemotherapy resistance lies on the cells itself. If they are able to improve their DNA repair. Some anti-cancer agent that targets the DNA, okay, they reach the DNA, but these cancer cells are able to repair it. Okay, so they have some mutations, okay, in the cells that can also block the apoptosis from happening. Okay, so the agents supposed to initiate the apoptosis in the cells, but it does not happen because the cancer cells can overcome or override the drugs. Okay, by their proteins. Okay, so example, we have a drug called cisplatin. This is an example of a classic alkylating agent, okay, from the platinum-based agent. Okay, so you have a cisplatins that should get into the cells intracellularly, okay, and act on the DNA ducts. Okay, and it should cause the apoptosis. Okay, so it should damage the DNA, and then if the cancer cells recognize, okay, there's some damage or they are hurt in their DNA, so they should start the apoptosis. But with this mechanism here, alright, so the cancer cells tak mati. Okay, they have a lot of mutation, so that's why this is what we call mechanism of resistance. Okay, and now we are quite about the same case with the antibiotic. So option kita is limited option of the drugs, but the mechanism of resistance, okay, they are getting wiser. Okay, the cancer cells are getting wiser. So for example, if you have mutation, okay, at the P53, and this one is common, okay, P53. So kalau you buy biochemical or blood test to check whether you ada this tumor marker kan, sometimes they look at the P53 and the fast, BAX or BAT, or BCL2 is common for the breast cancer. Okay, so these are all the mutation that can cause a mechanism of chemotherapy resistance. Okay, so again, the cancer cells become resistant by several mechanisms. First, they pump the drugs out of the cells by increasing the activity of efflux pumps. Okay, number two, reduce drug influx. Okay, 3, in cases in which drug accumulation is unchanged, okay, the cancer cells activates the cytochrome P450 complex. Okay, so they increase the metabolism of the drugs. Okay, cells can also activate mechanisms that repair drug-induced DNA damage, and finally disruption in the apoptotic signaling pathways. Okay, so these are the mechanism of chemotherapeutic resistance. Okay, so maybe as agent A or drug A, they use the chemotherapy resistance is due to the drugs, that less drug going in, less influx, and increased efflux, not so much on the cell's function itself. But maybe drug B, okay, the concentrations of the drugs in the cells is what you try to target lah, okay, so they achieve the minimum concentration, but because of the mutation of the cells, so the drug does not work properly. Okay, so that give a different response on the anti-cancer treatment. Okay, and for the chemotherapy agent, not necessarily we talk about a drug that can kill the cancer cells directly, straightforward. Okay, there are new agents, okay, now that we can actually divide into hormonal treatment, okay, specific inhibitors. There are also agents that's actually the antibody, okay, and then we have biological response modifiers, okay, and then vaccines. Vaccines is also considered as drugs, okay, but I will not cover here, right? Okay. So these are the new types of cancer treatment. Okay, we have hormonal treatments. These drugs are designed to prevent cancer cell growth by preventing the cells from receiving signal necessary for their continued growth and division. For example, breast cancer, ER positive breast cancer, estrogen receptor positive breast cancer. So they are feeding on the estrogen. Okay, so what we do is that we might want to give any agent that can stop the interaction between the ligand and also the receptors. So for example, kita bagi tamoxifen. Okay, and then we also have a specific inhibitors, antibodies. Okay, you all okay ke? Saya sudah cakap lembut-lembut sikit hari ni. Tak saya terbatuk. Okay, right. Rasa gloomy kan, nak hujan gitu kan. Lepas tu saya pula cakap lembut takut you all tertidur. Okay. Kalau rasa nak tertidur tu bangun duduk exercise. Okay, and then we also have biological response modifiers. For example, abscessimab, rituximab. Okay, this is a normal protein to stimulate the body's own defenses against cancer. Okay, abscessimab ni I think you dah pernah dengar lah sebelum ni in the anticoagulant lecture. It's a GP23A antagonist, but we found the evidence that abscessimab can be used to treat leukemia. Okay, but the mechanism is unknown. So masih lagi kita study abscessimab potential to be used as an anti-cancer. Okay, and then we also have the vaccines. Okay. So bila kita try to produce anti-cancer agents, there are several principles that we need to follow lah. Okay, first one is a single chronogenic cells can produce enough protein to kill the host. So kalau ada single cells pun, okay, you think that it can divide extensively. So daripada satu single cell tu dah boleh jadi colony and dia akan spread. So bila kita try to, let's say you want to you ada 30,000 of chemical bank, okay, yang ada potential, you screen, okay, tinggal 1,000 potential chemical. Okay, so you kena tengoklah mana yang paling bagus, yang paling potent. Sebab kalau boleh, katakanlah you ada 100 cancer cells, all the 100 cancer cells will die when you introduce this new agent, for example. Okay, tak nak ada 50%, dan separuh lagi tu what happen? Because kita the principle is kalau tertinggal satu, dia akan ada potential untuk jadi spread, okay, lebih banyak and form a new colony of progeny. Okay, unless a few malignant cells are present, host immune mechanism do not play a significant role in therapy of neoplastic disease. So memang kalau kita ni memang theoretically your immune system should fight the cancer cells, okay, but in most cancer patients they don't, right? So bila kita bagi treatment tu, kita tak nak, oh tak apa, we cover 50%, the other 50% the patient's immune system akan cover. Okay, there's no such thing as that. Okay, a given therapy results in destruction of a constant percentage as opposed to a constant number of cells. Therefore, cell kill follows first order kinetics. Okay, most of the recent progress using anti-cancer or anti-neoplastic therapy is based on development of new combination therapy of using existing drugs, better understanding of the mechanism of anti-tumor activity, development of chemotherapeutic approach to destroying macrometastasis, and understanding the molecular mechanism concerning the initiation of tumor growth and metastasis, and recognition of the heterogeneity of tumors. Actually, the information to cover all of this until now is quite enough. Because cancer cells ni kadang-kadang kita tengok lebih sama kan, bila biopsi berbeza. Contoh for example, let's say if you have a cyst, you look okay, daripada biopsi okay, hari ni nampak okay, sel tu the cyst tu lebih sama, ada 3-4. So hari ni the intention of delaying the regrowth of residual tumor cells. Okay. Then we also have a salvage, which is a potentially curative high-dose, usually combination regimen given in a patient who has failed or recurrence following a different curative regimen. Okay. Right, so kalau boleh kita nak semua patient response daripada awal lagi, daripada adjuvant, okay, and then induction, intensification and maintenance tu is just to make sure that they achieve a complete remission, and then the remission tu is long lah, okay. Tapi kalau berlaku juga recurrence, so we try to give a salvage, okay. Okay, so what are the classes of anti-cancer agent? Okay, this is a bit classic, yang classic agent. Okay, so we have an anti-metabolite, we have a genotoxic, which is a alkylating agent. Okay, and then we also have a plant-derived anti-cancer agents. Okay, that target the mitosis, topoisomerase. Okay, and we also have other agents with a different or various type of mechanism of action. Okay, so basically yang ada MOA itu ialah new agents. Okay, so bila kita kata new, okay, dia target differently, target specific receptors ke, or if they are antibodies ke, okay, different mechanism. But bear in mind, the latest drug usually is more expensive. Yeah, it's more expensive. Okay. Okay, so this is just sepintas lalu lah. Okay, bila you kata anti-metabolites, okay, the anti-metabolites will interfere the formation of the key biomolecules. For example, nucleotides or the building blocks of the DNA. Okay. And then we also have a genotoxic drugs. Okay, bila kita kata genotoxic drugs, this drug is toxic to the cells, they kill the cancer cells. Okay. Right, by targeting the DNA. And then we have plant-derived inhibitors of mitosis. Okay, so this agent blocks cell division by interfering with the cytoskeletal components that enable the cells to divide. We also have plant-derived topoisomerase inhibitors, okay, and other agents. Okay, so these are the anti-cancer drug groups. Okay, so agak banyak lah. Okay, right. So ni baru dia punya kelas, belum lagi example of the drugs. Okay. Boleh ingat semua ke? Tak payah. Oh, dia pula cakap kat saya. Tak tahu kalau keluar exam. Okay. So alkylating agent, we have anti-metabolites, we have a natural product itu yang plant derived, and then antibiotics. Okay, some antibiotic, walaupun you tak belajar lagi antibiotics, tapi some antibiotics are also anti-cancer agents. And then we have a miscellaneous anti-cancer agents lah with a different mechanism of action, various mechanism of actions. Okay, so each of these structure ni kita akan go through. Okay, tapi sebab dia banyak, so we for the pharmacokinetic parts tu you cari sendirilah. Okay, right? But most importantly is you know what this drug do. Okay, the mechanism of action, and if there is a serious adverse effect that we should make. Kalau tanya adverse effect, mestilah nausea, vomiting, headache, itu biasa kan pada kanser. Tapi kalau dia ada yang special adverse effect yang tu you have to remember lah. Okay, so for alkylating agent we have a nitrosoureas, okay, non-classic alkylating agents and also platinum analogues. Okay, for antimetabolite we have antifolates, chloropyrimidines, deoxytidine analogues, purine antagonists. Okay, and then natural products we have vinca alkaloids, taxanes, epipodophylotoxin drugs and chemtoticates. Okay, and then we have anthracycline, mitomycin, bleomycin as antibiotics. And then yang hujung tu is receptor inhibitors. Okay, so let's have a look at the alkylating agent. Okay, classic agents is the drugs and the alkylating agents that are composed of either bischloroethylamines, okay, or nitrosoureas moiety. Non-classic agent is the drugs that have similar mechanism of action involving DNA alkylation. Okay, so these are example of alkylating agents. So alkylating agent is the oldest anti-cancer drugs. Okay, so imagine the first trial is in 1940, so they have been using this drug for tidak berapa lama dah tu, and we still use some of the drugs now. Okay, right, the example is cyclophosphamide, mecloramine, chlorambucil, and menfalam. We have a busulfan, we have thiotepal, okay, and then this Samustine, methyl CCNU, lomustine, BCNU, carmustine. Okay. Bila ingat tu, you sebut. Bila you nak try to remember the name of the drug tu, you sebut. Then tulis. Okay. Still we got time before the exam exam. Okay. So, what is the mechanism of action? Okay, so this drug, how do they work? Okay, there's a formation of covalent bonding of a highly reactive alkyl groups or substitute alkyl groups with nucleophilic groups of proteins and nucleic acids, which form the cross-linking between two DNA strands or between two bases in the same strands of DNA. But this agents also have a secondary mechanism, which is a carbamylation, which is the addition of the carbamyl group on the lysine residues of proteins through formation of isocyanides. Okay, so what happened is that when they form this cross-linking, okay, they add the alkyl group to the DNA base. Okay, so the cross-linking is formed. Okay, then it causes the DNA strand breakage through scission of the sugar phosphate backbone DNA. Okay, so because they just target the DNA, okay, at any stage, so they are not cell cycle specific. Okay, the alkylating agent kill tumor cells in all stages, but the cells are most susceptible in the G1 and S phase of the cell cycle and express the blockage in the G2. Okay, so we have a picture here. Okay, right, so the green one is the cross-link. Okay, right, so you have a DNA. Okay, so if they are monoalkylated, so they only binds to just one, okay, base. Okay, and then interstrand cross-linking is when they form a cross-linking between interstrand. Okay, and then this one is intra-strand. So when they have this cross-link, the DNA will break. Okay, and they kill the cells lah. Okay, but what are the mechanism of resistance? Okay, first, increase capability to repair DNA lesion. decrease transport influx into the cells, increase production of the glutathione and glutathione associated proteins, and increase glutathione as transferase activity that deactivates the drugs. Okay. Cyclophosphamide has high oral availability, therefore it is administered by oral and also IV with equal clinical efficacy, but it has to be activated by liver enzymes. Okay, so let's look at the cyclophosphamide. Okay. The indication for cyclophosphamide include treatment of malignant lymphoma, multiple myeloma, leukemia, okay, neuroblastoma, and then the gynecological cancer. Okay, right. Mechanism of action is we have mentioned already. Okay, absorption, peak concentration occur at 1 hour. Protein binding is 20%. Okay. Metabolized by liver enzyme. Cyclophosphamide appears to induce its own metabolism, which result in increase in clearance and shorten the half-life following repeated administration. Okay, excreted unchanged in the urine, and a small amount is excreted in the bile. Half-life 2 to 12 hours. Toxicity, adverse reaction reported often include neutropenia, febrile neutropenia, fever, alopecia, nausea, vomiting, and diarrhea. Okay, so that's just example. So since we have many anti-cancer drugs, so if you want to know more, you can just refer to the names lah. Okay, about their punya specific pharmacokinetics profile. Okay. Then we have a non-classic alkylating agent. Okay, for example, flucarbazine, dacarbazine, bendamustine, and platinum analogs. Okay, so let's have a look at these platinum analogs. Okay, what is platinum? Platinum tu apa? Besi. But it's okay. Okay. So this is a platinum analogs. For example, cisplatin, carboplatin, and oxaliplatin. Okay. So kalau dia alkylating agent, mechanism dia sama sajalah. Okay. So the formation of alkyl groups that binds to the DNA base pairs, okay, that form a cross-link to DNA scission. Okay. So senang, it's easier for you to remember the mechanism of action. It's just that this group is a platinum analogs. Okay. But in addition to the mechanism of action, the platinum analogs also binds to some of the cytoplasmic and nuclear proteins. Okay, and this analogs synergize with certain anti-cancer drugs, including alkylating agents, fluoropyrimidines, and taxanes. Okay, elimination mainly by the kidneys. Cisplatin and carboplatin is used to treat solid tumors. Okay. Carboplatin has significant less renal toxicity and GIT toxicity. Okay, so in some setting we still use cisplatin, but we found out that based on depends on your settings and also the patient status, you can change the cisplatin to the carboplatin. Okay, tengok regimen, the gold standard of the regimen for the type of cancer. Tak saya nak memang je.